Greetings and welcome to this video on hepatitis B. It's an overview. This is the first part of the video of this hepatitis B series. In this video, we'll discuss about the introduction, etiology, and the pathogenesis of hepatitis B, the diagnostic approaches, and the phases of chronic hepatitis. We'll touch the basics about the management in this video. In the upcoming video on the part 2 of hepatitis B, we'll discuss in detail about the hepatitis B treatment. So this is completely for educational purposes and it will be much useful for the currently practicing physicians and medical students. This is Medicine Beyond Harrison's. If you are new to this channel, do subscribe. Let's get started. So hepatitis B is a globally epidemic disease with affecting 296 million people affected globally. Southeast Asia has around 3% prevalence. India being 29.8 million cases all over India. So it is basically a DNA virus transmitted via blood, body fluids and blood. So asymptomatic, it can be, then it can go into chronic hepatitis phase, then go into cirrhosis, and then finally leading to hepatocellular carcinoma. The transmission, mostly by vertical transmission. 75% of infections are mother to child. Vertical transmissions have higher risk of chronicity. Around 90% of the children are infected less than 6 months and develop chronic hepatitis B. So, pregnant women overall prevalence is about 0.85% of age 15 to 49, with the highest prevalence in the Bihar with 1.46%, Mizoram 1.38%, and Delhi 1.36%. Pathophysiology and cancer risk basically it's a prolonged infection. There is a decline in HBsAg specific T cells and elevated HBsAg and elevated HBV DNA. These all lead to the increased cancer risk. So persistently high HBV DNA strongly associated with cirrhosis and hepatocellular carcinoma. The risk is independent of ALT levels or the symptoms. So ALT level doesn't actually matter during treatment of hepatitis B because independent of the ALT levels, it can lead into cirrhosis and hepatocellular carcinoma. Physicians must understand hepatitis B. In the wards, you can detect an hepatitis B during a surgical patient undergoing a surgery and routinely check for a serology and turn out to be hepatitis HBsAg positive, or you can suspect hepatitis B in a patient with jaundice and all, and a patient with fatigue and with pruritus. All these cases, you can suspect an hepatitis B, do a serology, and find HBsAg to be positive. So, what more to do? What next? So, this is what we will learn in this video. So, effective management requires understanding the core viral pathophysiology, the diagnostic criteria, and the treatment indications. The goal in this video is to prevent complications and improve the outcomes, and to train the common general physicians in the country to control the hepatitis B transmission and the treatment of hepatitis B. So now you got an HBsAg positive subject. So we'll go find out how the patient got this virus, either whether it is horizontal or the vertical transmission. Ask for the history, and the family screening is very very crucial. So once you know about the HBsAg is positive, then you have to check for HBC total, anti-HBC total, then anti-HBe and anti-HBs. So now when HBC total comes positive, then you have to check for anti-HBC IgM, which tells it is acute hepatitis B and not chronic. Anti-HBe suggests that it is highly replicating virus and highly infective patient. So anti-HBs suggests it's a past infection or the patient might be vaccinated. So approach to a HBsAg positive patient, always check for ALT and HBV DNA also. So fibrosis assessment, FIB4, APRI score are non-invasive methods to suggest fibrosis. You can do a elastography or the Fibroscan to look for fibrosis, which is also one of the gold standard methods. Now we replace the biopsy. So screen for cirrhosis and other comorbidities. So when to treat? So these were the past criteria. So past criteria suggest that fibrosis average score of 0.5 or elastography of more than 7 kilopascals, or when the viral load is more than 2000 and ALT is more than upper limit of normal, cirrhosis of any stage, co-infection with HIV, HTV, and HCV. In all these cases, treat. Additional triggers for treatment could be like additional comorbidities such as diabetes, glomerulonephritis, vasculitis, liver cancer, and cirrhosis. If none, monitor. But nowadays, we prefer the treat all strategy because we just got to know that the AST levels, the DNA level, DNA titers, the fifth floor elastography scores, all does not lead to the um, prevention of hepatocellular carcinoma. presence of HBsAg and the active infection itself is more than enough to make the liver and go into hepatocellular carcinoma. So to prevent that, now we adopted treat all strategy. So antiviral therapy and monitoring, nowadays we prefer tenofovir anticavir. Tenofovir can be tenofovir alafenamide, tenofovir bisproxil, fumarate. Both these drugs are also available. So it's usually continued lifelong these days. So we cannot stop this drug, but better to continue for lifelong. So monitoring every 6 months, you have to monitor ALT, alpha beta protein, ultrasound abdomen, and adherence check. So every 12 months, do an HBV DNA titers. So this is the most important takeaway slide that you need must remember when you treat an hepatitis B. So when a chronic infection is there, when HBeAg is positive and so HBV DNA is more than 10 power of 7 upper limit of normal and near upper limit ILT can be near upper limit of normal. Histology can be minimal percentage. This suggests HBE positive chronic infection. So this is infection, whereas this can be hepatitis when ALT is elevated. So viral load can be 10 power 5 to 10 power 7 with the histology of moderate to severe changes. So HBE negative, but chronic infection is there when HBV DNA titers are high, HBeAg antigen is negative, near upper limit of normal or no or minimal histological changes. So HBeAg chronic hepatitis is that when the viral load is detected and the ALT levels are elevated. These are the four different types of chronic hepatitis that we usually face in the patients. Does normal ALT means no disease? No, that is not true. Incidentally detected asymptomatic HBsAg positive subject. The IDAHS concept has come so that up 40% of normal ALT patients can have significant fibrosis. So immune tolerance is a misleading term. So 25% develop flare within 5 years. So normal ALT is not equal to no disease. So check ALT 4 to 6 months, rise of more than 2 to 5 times the upper limit of normal, treat. So how to write a diagnosis in a case sheet or for a discharge summary or for a home prescription. So your diagnosis should be complete approach to a hepatitis B. So always you have to write about the HBe antigen status. HBe antigen, if it is negative, then write negative. If it is positive, write positive. Whether it is acute or chronic, and then if it is a chronic hepatitis B, write chronic hepatitis. Then if there is a fibrosis, cirrhosis or not, then we will write that. Whether the cirrhosis is compensated or decompensated, we will write that. So all these things should be there in your diagnosis. So newer diagnostic tests, these are upcoming tests currently not available widely in India. So hepatitis B core-related antigen, HBCR antigen, is a composite of HB core antigen and HB envelope antigen and the pre-core protein, the P22CR. It has a prognostic indicator, now not commonly used, it's an upcoming indicator. So HBV RNA, it is measured in the blood, correlates with CCC DNA activity. Components of diagnosis: E wild high DNA titer, E mutant have low DNA and aggressive flares. So these are the types of viruses present in the this thing, hepatitis B and HBV DNA titers and QHBsAg antigen is also measured. Liver status, you can look for inflammation by AST and ALT levels, fibrosis by biopsy or FIB score, APRI score or the Fibroscan. Complications, you can expect decompensation as well as hepatocellular carcinoma. So nowadays, this HBCR antigen, higher chance of HBs zero clearance, lower at start therapy, higher chance of HBe zero clearance at when it is low at the start. High HBCR antigen leads to higher HCC risk. So this is as a prognostic indication. So if it is available in your center, we will do that and check for the prognostic markers. So HBV RNA correlates with CCC DNA activity. High levels during therapy increased risk of HCC. Non-invasive fibrosis assessment, the shift to guidelines now emphasize non-invasive test over biopsy, such as Fibroscan or APRI score. APRI score is AST to platelet ratio index. It is also a very good index to look for the absence of fibrosis. It is cost effective as well as convenient to prevent the invasive method of liver biopsy. Liver biopsy is gold standard, used rarely nowadays. In case of hepatitis B, for other indications, you can use reserved for diagnostic dilemmas only. So the aptly score, if it is significant, if it is more than zero point 0.5, and cirrhosis, it is if it is more than zero point 0.1. Fibroscan measures the liver stiffness. If it is more than 6 to 8 kilopascals or the 7, it is significant. If it is more than 11 to 14, it is a definitive of cirrhosis of liver. So read from the WHO 2024 guidelines. This is the core indicators. APRI more than zero point 0.5, Fibroscan more than 7, active disease DNA in more than 2000, ALT elevation with vasculitis or glomerulonephritis. When all these features are there, you have to treat. So, in case of high risk patients such as diabetes, metabolic associated fatty liver disease, and then immunosuppressed co-infections with HIV, HCV, HTV, family history of hepatocellular carcinoma, in all these cases, treat regardless of the DNA levels, ALT titers, Fibroscan or API scores. Now, it is the new approach, universal treatment approach. It is the treat all strategy. Better to go with the treat all strategy because even low DNA, normal ALT carries the risk of hepatocellular carcinoma. It also prevents the horizontal transmission also. So always go for this treat all strategy. So drug classes, we will discuss in brief about the drug classes in this video. So um, interferons, which are previously used, nowadays not commonly used, is an immunomodulator, inhibits viral RNA transcription. These are the common things you need to know about interferon in current era. So nucleotide and nucleoside analogs. So these are direct inhibition of HBV DNA polymerase and the chain termination which leads to reduced replication of the virus. So preferred antivirus are nowadays only these three things. How to use it, when to use it, we'll discuss in the upcoming video. So tenofovir disoproxil fumarate (TDF). It is 300 milligram once daily dosage. It cannot be given in renal failure patients. So tenofovir alafenamide, this is a better drug, safe for bone as well as kidney safe. It is only 25 milligram once daily, but it's a costlier drug. Entecavir is preferred mostly and widely used. It is 0.5 milligram once daily. But in case of decompensated patient, it's 1 milligram per day. It is 2 tablets per day. So these are high resistance barrier drugs. These can be used nowadays. Special drug consideration for renal and bone disease, prefer entecavir or tenofovir alafenamide. Assess baseline renal function always. Adjust doses accordingly. If drug resistance, so there is exposure to prior lamivudine or lenofovir failure. Switch to tenofovir or tenofovir alafenamide. Regulatory interferon or previously used was given subcutaneously for 48 weeks. HBsAg loss is higher, relapse risk is low. Now this new nucleotide or nucleoside analogs, these are given orally. Duration is variable, almost given lifelong. So HBsAg loss is lower, but relapse risk can be higher compared to regulatory interferons. Treatment goal is now the viral suppression. Viral suppression, biochemical response with decreased HBV DNA level and normal ALT levels achieved in more than 90% with this newer current treatment with tenofovir, entecavir, or tenofovir alafenamide. Functional cure is undetectable HBV DNA plus HBsAg loss achieved in less than 10% currently and also leads to lower HCC risk. So together we will discuss more about this hepatitis B virus and its treatment and the prevent the transmission, horizontal transmission, and they treat the hepatitis B as per the guidelines for your patients and do well for your patients. This is Medicine Beyond Harrison's. If you're new to this channel, do subscribe. Thank you for watching.